I'm your host, Kiera Deneen, and today our topic is the future of pediatric genetics. So we have lots of questions to answer about this. Our guests are Dr. Jerry Vockley and Dr. Stephen Kingsmore. They are going to be providing us expertise in this area of pediatric genetics. Quick overview of the session. We're going to be starting with an interview with our two panelists here, and then we're going to be taking your audience questions. So feel free to ask questions throughout the session. We'll get to those at the end. You can use the question and answer box, the Q&A box at the bottom of your Zoom call if you're watching this through Zoom, and we'll be sure to get to those at the end of the session. And a quick note about PhenoTips. They are the world's first genomic health record system. They have software and services that ease genetic professionals' workflow, tools like pedigree builders, standardized symptom capture, and diagnostic insights. As many of us know that work in genetics, electronic health records are not built for genetics, so PhenoTips helps to fill in the gaps by providing complete suite for genomic medicine. And in light of the pandemic, PhenoTips is sponsoring this PhenoTips Speaker Series so that we can connect with individuals throughout the world to come together to talk about genetic topics and issues within our profession. Again, I'm Kiera Deneen. I'm the host of this webinar. I also host DNA Today, which is a genetics podcast. We won the Best 2020 Science and Medicine Podcast Award last year. And over the last 9 years, we've produced 150 episodes. So if you enjoy our conversation today, be sure to check out our other conversations on there. And I'm also a prenatal genetic counselor. So Dr. Kingsmore and Dr. Vockley, I would love for you to introduce yourself, tell the audience a little bit about your background.
Stephen, go ahead.
Okay, thanks, Jerry. I'm Stephen Kingsmore. I'm the president and CEO of Rady Children's Institute for Genomic Medicine. I've been here for 6 years. We are part of Rady Children's Hospital, which is one of the largest children's hospitals in the US, and we're located in San Diego. So we're a new research institute, and our focus is exclusively on changing pediatric care by introducing genome information as part and parcel of that care. And we not only have a local focus in San Diego, we actually provide genome sequencing services to about 70 children's hospitals around the US.
Including here in Pittsburgh, and thank you, Stephen. I'm Jerry Vockley. I'm the Cleveland Family Endowed Professor for Pediatric Research at the University of Pittsburgh School of Medicine, and I hold a joint appointment as Professor of Human Genetics in the Graduate School of Public Health. I serve as the Chief of Genetic and Genomic Medicine for the Children's Hospital of Pittsburgh and its Director for Rare Disease Therapy. I see patients, I do research in the laboratory, and I do a lot of clinical research. So I come at genetics really from a full focus across the spectrum of where I think we've been and where I hope we're going.
Yeah, thank you so much. Great intro. And I think today we're going to be talking a lot about what is happening right now in pediatric genetics, but also looking at the future, as you just said, Dr. Vockley. I thought we could start out with laying the foundation on what a first consult is in pediatric genetics and what that workflow is like in that first session. Dr. Kingsmore, did you want to start out just sharing what that first consult looks like for an average pediatric genetics visit?
I would not, actually. The last time I saw a patient in a first consultation was 1997.
So it would be a historical context.
I'm going to let Jerry do this one.
I'll take that. I'll take that rebound and go back up to the hoop. It's a mixed bag. So genetics has a tradition of being a diagnostic discipline, and we also are often viewed as sort of the diagnosticians of last resort. So many patients have come to us from a diagnostic journey that is long in the process. that's changed a little bit, and I think we'll get into that as the hour goes on. But I think the context of the first evaluation probably hasn't changed all that much. It really is a traditional medical evaluation. That is, you do a history and a physical, and when all and you use that to direct your testing. The difference is that our physical is more than vision, hearing, listen to your lungs, listen to your heart. It's measure your eyes. It's check the rotation of your ears. So it's all of the dysmorphology things that we learn in our training. That help focus on the physical disorders, or the disorders, I should say, that have physical manifestations that might be recognizable, the things we call syndromes, and then also to think about the broad categories of disease that have much more broad phenotypes, so something like developmental delay or intellectual disability, failure to thrive, which can include many of those genetic syndromes that we talked about, but also things like inborn errors of metabolism. So we're also doing genetic, we're doing lab testing that focuses on metabolite analysis, genetic analysis. And then the piece that I purposely saved for last is the one that probably distinguishes us as much as anything, and that's our pedigree analysis, or our family history. The key to this component is really our collaborative efforts with our genetic counselor colleagues, not only do they draw better than I do, they're way more complete when they do their genetic histories or their family histories than I am, and it's because I know I can rely on them to do that. It obviously points to specific modes of inheritance if you identify them, and disease entities that fit those, and along with your clinical picture. So history, physical, family history, and genetic and metabolic testing are the first order of business.
And how did the pandemic affect, part of the visit, as you're talking about, is the physical assessment part. How has the pandemic affect that? Because telehealth has become such a major part of the pandemic response, and a lot of genetic counseling can be done that way in terms of, as you were mentioning, taking a pedigree with that family history, but physical, that's quite hard to do, in terms of measurements. And as you said, like rotation of the ears. What's been part of your response to that?
Yeah, so there are a couple of kinds of telemedicine. Telemedicine with which what I call a casual physical exam. I can see you sitting there. You're alert. You're not in any acute distress, and I think it's fair to say you have no dysmorphic features. So you would pass first muster in a quick telemedicine visit.
Right, you can't see my ears, but everything.
Yeah, that's
else,
right.
right?
You're covered up. You're covered up. So I wasn't going to comment on these strange things coming out of your head. But there is a much more sophisticated way to do a telemedicine visit. The more formal version of that, which we were doing prior to COVID, which was to bring a patient into a room remote with an assistant who actually has instruments that you can use. So you can use a USB stethoscope and listen to somebody 1,000 miles away, or an otoscope and look in their ears. So there are ways of doing that. And then when you have a high resolution handheld camera, you can also say, okay, zoom it in on the eye, and I can see your irises. I can tell whether you have a stellate pattern there or not. And if it really comes down to it, if you've trained your assistant at that remote site, you can say, please measure the palpebral distance for me. So you can do a relatively robust exam remotely that way, but it's not what was usual during the pandemic. That first example was much more what we were encountering, trying to put our finger in the hole in the dike and get through the acute process. And I say we only lost about 3 months worth of face-to-face time throughout the whole pandemic, so it really wasn't all that bad in that regard.
And Dr. Kingsmore, I'd love to have you jump in terms of other challenges that you've seen facing pediatric departments and really the field in general, of what you've noticed the past couple of years.
Well, in response to COVID, the main thing has been that 1 week we're wearing masks and the next week we're not, and 1 week we're virtual and 1 week we're not. And it's been an incredibly tough period to sort of lead a research institute. Innovation and creativity happens often in those magical spark moments where you encounter a colleague and you have your aha moment. And Zoom has to be the enemy of creativity, so that's been a huge shift. How do we measure productivity and creativity? How do we maintain morale? These are huge challenges for our field. And I don't know that anybody has really great answers. I think we're struggling to do the best we can, but I do think probably the world has taken a major hit in terms of research productivity and creativity as a result of the pandemic.
Yeah, I think that's a good point, and just the impact not only just on direct patient care, but on a larger scale, like research projects and parts that some can be done virtually from home, but just that collaborative nature and coming up with ideas, and that is more likely to spark in person, and when you're having those water cooler moments and things that you're not going to have through Zoom. One of the other questions I had for today is looking at the latest technical advancements in the pediatric space. What have you noticed in the past few years that has really shifted either, this specialty or things that you have seeing maybe coming up on the horizon? Dr. Vockley, did you want to start out?
Sure, I'll start out with right and take us right to where Stephen is now, because he is the cutting edge, and he should address that. I would say that we've had really two major revolutions, if you will, in genetic testing in the last 20 years. The first, which was the last 10 to 20 years, was the mass spectrometer. And that was very, very straightforward metabolite analysis. We went from having to order one test at a time to being able to look at a lot of things at the same time. And the more sophisticated the technology, the more things you could pick up. And as that manifested both in the clinical setting and newborn screening, it really brought us patients who were diagnosed fairly definitively for the most part, earlier than we might otherwise have, and allowed us more sophisticated ways of following our therapy. So that was the 20 to 10 years ago. Starting about 10 years ago, we moved from the era of pick a test on the molecular side to first bundling things in packages, but really, let's just jump straight to exome, because that's the logical place to talk now. Which is to say, instead of having to pick a test, you could identify a need And now the test was there that covered that need regardless of it was what the need was, and it was relatively inexpensive, regardless of what some of our insurance colleagues would have you believe. Anytime I talk to an insurer about not covering an exome, my standard response is, "What about better care at lower cost? Don't you understand?" So the idea that I could look at a patient and phenotype them, come up with a physical map, if you will, that said, I think they have a syndrome. Well, we now know that syndromes are heterogeneous. There's allelic and there's locus heterogeneity, and the only way we know that is by looking. And the harder you look, the more you find. The other thing we know that a lot of the variability in diseases that we've identified in the past is because some of those patients have had two things. Half of our patients have two, not half, I'm sorry, 5%, take a zero off, have two things. And that explains the heterogeneity in those individuals. So the leap from that first evaluation to going to whatever the latest, greatest definitive test is in genetics has compressed almost to zero. I mean, our testing paradigm in Pittsburgh is, if you think you know what it is, you can go ahead and order a specific test, or if it's a panel that covers the diseases well that you think, that's fine, go ahead and do it. But if you don't, or you thought you did and you got it wrong, no second chance, you go right to an exome. And I think that the going forward, that's going to be a genome as opposed to an exome. It's just the only thing that makes sense.
So at some point, I would imagine we're just not going to have gene panels anymore. It's just going to move to exome and then maybe eventually whole genome. Do you see that happening in the near future, or are we still a ways away from that?
Stephen, you got it. Go for it.
We've been doing genomes for 6 years. We don't really do anything else. So we're big believers in the power of a genome. I don't really see a reason not to do a genome in an individual. I think the other tests are transients. They were instituted initially because people were afraid of the data load, and it was more costly, and both of those have gone away. So I think we still have these legacy tests that are still frequently ordered, but genomes are where the action is. The genome is more complete. It's the most complete test currently. It covers about 90% of the genome. It replaces a battery of things that we used to do. So it covers both the nuclear genome and the mitochondrial genome. It covers structural and copy number variants as well as nucleotide variants. So it's basically a one-stop shop. There are some disorders it doesn't cover, but even in those disorders, you can impute. So even for, say, methylation disorders, you can get information from the genome, which makes a suggestion to help you. So genomes are written. Now, the biggest advance to me is that we now no longer take a month to return a result. We can do it in a day. We just published a paper in New England Journal. It was a letter, really. Staggering case, 13 and a half hours from receipt of a blood sample to delivery of a diagnosis, and 37 hours from symptom onset to putting them on a life-saving medication in a disorder that was so rapidly progressive that even had we waited 3, 4, 5 days, that child would have been neurologically devastated. So that's the future to me, is instant genomes. They're either pre-done or else they're immediately done. And then merging that with AI, that's the other huge piece. A genome without artificial intelligence and big data handling capabilities doesn't really work. So that's the other thing that we have been talking about for decades, is big data. And it's happening now in pediatrics. where we are able to realistically look across the genome in real time and use that to drive patient management. It's exceptionally exciting. It's rewriting the book of what's the standard of care in several pediatric subspecialties.
And so different because we hear like the diagnostic odyssey is a term that's used a lot, especially in pediatric cases where you have someone that, maybe has a diagnosis, but then gets re-diagnosed with something else as more symptoms come up, more information's available. But, you're talking about this case where in 13 and a half hours, you have a result. And, you said like 30 something hours from first symptoms to having a diagnosis. That is mind-blowingly different than what we've seen for the diagnostic odyssey of being years long. You're talking about hours long. So that's just like mind-blowing to see that is where we are today. And that, as you saying, like becoming more of a standard of care with that. Do you have most patients doing trio testing with genome, or is it really just starting with patients? Like what's the population that you see in terms of samples being run?
It's an interesting question. In the United States, we have a law that protects privacy related to genome information called GINA, the Genetic Anti-Discrimination Act. Unfortunately, that doesn't apply to all of our population. Here in San Diego, we're a big naval facility and a big Marine Corps facility. And we have to caution parents if they are employed by the Navy or the Marines, you're not covered by GINA. So we may not want to decode your genome because it could have implications for your career. So that's a setting where, you need to be thoughtful and give appropriate genetic counseling. But by and large, if we can do a trio test, that's a faster test and it's a more definitive test. What we have become aware of, much to our surprise, is that the majority of diagnoses of genetic diseases are de novo variants. We've rewritten the textbook. We used to think the burden of disease was overwhelmingly recessive. Well, it's not. It's just we didn't pick them up before. Really the only way to know whether something is de novo or not is to have the parent genome or the parent sequence at that locus. Well, if you're going to just decode that locus or that variant, you've got to order primers and so on, and that delays turnaround time by, 3, 4, 5 days. So really, if we can, and if it's safe to do so, it's really smart to get mom and dad. The other issue, though, is that we have fragmented families very often. And so we may have mom, we may not know who dad is, or dad may not be available. So there's these practicalities. I mean, a duo doesn't help you really. So it's singleton or trio.
Is there ever cases where you have, say, the patient has a full sibling? Would you look at their genome to give any extra information, especially in cases where one of the biological parents' sample isn't available or it doesn't make sense to do for, GINA reasons, as you pointed out with military, either if that sibling is healthy to kind of rule out certain variants, or if that sibling is also a patient and having possibly the same disorder? Do you see that in conjunction with each other, or is it treated separately?
There are some families with multiple affecteds for sure. And generally this happens more as a reflex. We diagnose somebody in the family. We are doing our pedigree analysis, as Jerry spoke about. And we realize we want to screen the family and make sure that there is not another affected. So that's generally how it happens, rather than having another affected sibling on the front end. We're mainly dealing with babies and children in intensive care units. Again, right now with COVID, we're not going to see that sibling. They're allowed kind of one parent to be visiting at a time. So for this acute setting in general, no, that's not the case.
And how about when we look at, talking about switching over to leaving gene panels behind and really switching to either whole exome or whole genome sequencing? do we see this possibly replacing newborn screening? I mean, maybe we should give a little background information. Dr. Vockley, I don't know if you can speak to what newborn screening is. It differs by state, but maybe what the core is for the US before we jump into what could happen in the future.
Yeah, newborn screening is traditionally a functional test. Hemoglobin, G6PD, enzyme analysis by biotinidase, galactosemia, ureadyl transferase, or metabolites as picked up on the mass spec. And there are other now conditions being added, LSDs that are enzyme assays, X-linked adrenoleukodystrophy, which is a metabolite assay, severe combined immune deficiency, the first direct molecular test. So it's expanding, and there is a federal panel that's empowered within HRSA that sort of ruminates on these diseases and decides which ones are ready to be added to the national newborn screening sensorium, if you will. There is no national screening mandate, but there is a recommended uniform screening panel, the RUSP. And then each state is allowed to pick and choose from that RUSP and do their own. But for the most part, across the United States, we're pretty close to everybody doing what's on the RUSP. Now that amounts to, depending on how you count them, 36 primary diseases and another dozen or two secondary ones that are identified because you're looking for something else and you get the other ones as a result. Now that's a far cry from the however many thousand genetic diseases you believe there are, 8,000, 10,000, 12,000, I don't know. And the question then becomes, what is reasonable to know and when? I find that there is a lot of merit in the idea of screening for something that's going to impact a baby in their first year of life when they're born. Because when are you going to impact, when are you going to be able to do something about that? Probably if you start early. If it's something that's going to be developing when they're 10 and there's no problems between now and then, would you want to pick that up as a newborn? Well, I wouldn't, but I think that you make this argument for every increment of 5 years across the life. So rather than newborn screening in genetics as the future, I like to refer to as age-appropriate screening. And the nice thing about genome data, for example, is that genome data doesn't change. If we were to do a whole genome on everybody, hold your technological gasps there. That all we did was pull out the relevant newborn disorders. Maybe they're even used as follow-up for standard newborn screening to confirm the result, but mostly they're going to be used for their own purposes. And you say there's 200, there's 300, there's 700, whatever the number is of diseases that impact an individual in the first year or two of life, and you give a readout on those. And then you put it back in the system. And here's where the EMR becomes critical. You got to be able to go back in and query it again. So now, just like when you go into the pediatrician's office and they look at you at 1 year of age and they're doing their Denver developmental assessment and they're looking at it and they say, oh yes, you're due for your hemoglobin analysis to see whether or not you've got anemia, and you're due for your shot, and let's check your next year's worth of genetic diseases that we want to know about. Out it comes. And that's the power of a data source that you can go back to, and using it in an age-appropriate fashion rather than a one-size-fits-all. Let's just tell everybody what's wrong when you're a newborn, and now where our fates are all written for us.
I think that's a fantastic idea, because you can cover more conditions that are going to affect in the infantile period. So of however many conditions that is that we can identify through the genome. And then, as you're saying, as time goes on, checking back in, and the genome doesn't change. We're born with the genome we die with. So looking at those certain points and saying, okay, now they're 10, as you said, now let's look for more conditions that would affect childhood. And then, as you get older, maybe in your late 30s, 40s, looking for different hereditary cancer syndromes. I mean, this could impact, we're talking about pediatrics today because that's what we're focused on, but really scoping out a little bit more, this would affect every area of genetics. And even if you think about, you go to a psychiatrist, you're looking for what medications may work well with you.
Sure.
Say, well, let's bring up your genome and see what variants you have in certain genes that may predispose you have a more favorable outcome to certain medications. So I can see this just, really projecting out past the pediatric area with that. I can see you've really thought all of this through.
And that really brings you to the more broad topic of precision medicine. I like to argue that genetics is precision medicine. That's what the genome is. We're telling you exactly what you've got, and as soon as we understand what it means, we'll tell you that too. And that's going to be the leaps and bounds that have to be made. But there's no reason to be practicing pediatrics. There's no reason to be practicing medicine. There's no reason to be practicing ticketed specialty cardiology the way we practiced it 40 years ago. We should be so far beyond that. And it all starts with a relatively inexpensive test that you can get back in a day. I mean, what's not to like there?
I think the other thing that would be pushback is who's going to pay for this. Newborn screening is relatively inexpensive. And I mean, we've had that in place for a long time. It's changed over the years, but we've had that in place for a long time, like starting with PKU and everything. But, when you are jumping to genome, if you're looking at that being done for all newborns, just like newborn screening, I think that would be the pushback for people more on the insurance side of, is that insurance paying for that? Is the government paying for that? Where's that coming from? Because insurance companies only are looking at the short term. They're not really looking at the long term, because if we look at someone's life, is this worth doing? Yes, because all these areas where you're going to be using the data. But I don't know if you have any thoughts about that, Dr. Kingsmore.
I love stories, so let me give you a little story. This is the story of Fitz. So Fitz lives on Coronado Island with his mom and dad, which is where I live in San Diego. So 2 years ago, Fitz was born, and he had a positive newborn screening test for SCID, severe combined immune deficiency. Now, that newborn screening test is a general test. There are a number of conditions that trigger positivity. So at 4 days of age, his parents were contacted and he was brought back into Rady Children's Hospital. We decoded his genome. It took 92 hours. And we found out he had Artemis SCID. Now, normally with this disorder, you die at about 1 year of age of infection. Instead, what happened with Fitz was he was transferred to UCSF, where he became 007. He became the 7th patient to receive gene therapy, ex vivo gene therapy, to replace his broken Artemis gene. He never had an infection, right? So he was born with a positive newborn screening test. He had a lethal genetic condition, and he never in his life experienced a single infectious episode, and he no longer has that disease. That's the future, right? That's what we want to make available for every genetic disease. And this is really now within reach. This is not science fiction. There's a drug called Millicin, and Millicin is a genetic therapy made for Mila. So this was a drug made for a specific patient with a specific genetic disease, and it took only a year to go from concept to Mila getting her drug. That's the future for us. We need to shift our thinking, though, so that we're not thinking about disorders, we're thinking about variants. The public all knows what a variant is now, right? So we need to be thinking about newborn screening for variants, because genomes pick up variants, they're agnostic to disorders, and genetic therapies are agnostic to disorders. They also treat variants. So that's this new magical world that we're going to be in over the next decade. Is what's the variant? pool in your genome? Is there anything there that we need to target? And then what's the right agent to target it with? Both platforms, a genome platform for discovery and a genetic therapy platform to fix it.
And that genetic therapy that you're talking about with that patient, was that CRISPR based, or what was the technology behind the genetic therapy?
CRISPR's not quite there yet, hugely promising, but very new. This is allele-specific oligonucleotides. They're what right now are transforming the world. You know, you take a disorder like Duchenne muscular dystrophy, tragic disease, huge burden, fairly frequent in the population. Well, we now have genetic therapies, 4 of them, directed against different variants within the dystrophin gene. The bottleneck now is it's not on the newborn screen. This is another reason why we need to switch from testing for disorders to testing for variants and using genomes so that we could immediately at birth know, hey, you are going to develop Duchenne muscular dystrophy. We're not going to wait until you're symptomatic. We're going to get you on therapy immediately.
And Kira, just to bounce back to your original question for a second, who pays for this? The question is not who pays for this. Remember, my original challenge to insurers is, what about better care at lower cost? Don't you understand? Because what Stephen just described saved those insurers probably millions of dollars in hospital fees and therapies. If you get in, you identify a disease correctly, quickly, and you treat it right, you save money, and the cost of the testing in the end is almost insignificant. Stephen and I are involved in a study right now, a national study on looking at rapid turnaround whole genome sequencing in the NICU setting and its impact on not just how effective it is. Stephen's proven a number of times now that it's very, very effective, but what's the impact on the outcome of the babies as well as the medical economic impact? We're just closing in now on our 400th baby in that study. At which point we'll be closing the formal enrollment in the study. Hopefully we'll keep the sequencing going, but we'll close the formal enrollment, and we'll see what the impact on the cost of treating those babies was in the first year of life. We'll be able to go back to historically for matched controls for the same conditions. We'll have then an unequivocal read on how this is not just improving lives, but improving healthcare. UPMC is an academic medical center, but it's also a health plan. And if I don't take care of my health plan, they're not going to take care of me. So I want to be able to give them the best available therapy at the lowest possible price, and that's what this ends up being.
I think that's very well said, and that insurance companies just need to catch up with that, because as you said, even within a few years, hospital visits and all of the costs associated with a condition and taking care of that condition, even when you factor in parents needing to possibly take time off from work and not being able to make as much as they were, like there's just so many downstream effects of that. So I think that's a really good point, and just shedding more light on why this is already worth doing, because sometimes the conversation is, when is it worth doing? When will we get that return on investment? And you're like, it's already here. That's not really a valid question anymore. That it's more about showing that is true and providing that for insurance companies. I think the other aspect is that I think about when looking at taking this genome data is that with variant curation, that's something that's ongoing. Our genome doesn't change, but our understanding of the variants and the impact on our health, that does change over time. If someone has their genome done and, say that they were diagnosed, they found what they were looking for, should they revisit that genome certain increments of time to see if there's any updates in terms of other conditions, or for those that maybe weren't diagnosed and checking back in? Dr. Kingsmore, do you have a is there a recommendation for that time period of if it's 6 months, a year, a couple of years to check back in with the data?
This is an evolving field, Kira. Most of our energy, 99% of our energy, is focused on how do we end the diagnostic odyssey for a child. It's getting that first genome test. That's where all of our energy is focused. But you're right, we're going to move into an era where we've overcome that hurdle, and it's now somewhat standard of care for you to get a genome type test early in symptomatology. And then the question will be exactly what Jerry was talking about, this idea of staged unveiling of the genome, because the genome is a very rich information source of all kinds of information that some individuals will want to have knowledge of, others won't. And so certainly when you have a negative genome and you still have symptomatology and your physician is saying, I still think this is a genetic disorder. And we often see this, you know, they have a metabolic anomaly or they have symptomatology that's highly suggestive of a genetic disease and then a negative genome. We frequently have clinicians say, would you reanalyze the genome for me? The same is true as symptomatology changes. The disease progresses. There are new clinical features. It means we're going to look at a different set of disorders because always when we interpret genomes, it's phenotype driven. So when the phenotype changes, you probably are going to be looking for a different set of candidates when you inspect the genome. So that's happening more and more. I think we don't exactly know how frequently that should be done, but maybe that's once a year. It's going to vary. And obviously it's going to be driven by the clinician and their tenacity. So there's an awful lot to fill in there in terms of guidelines and the evidence that supports those guidelines for reanalysis.
Yeah, Kara, I can give you another example. We talked about the NICU project that Steve and I are involved in. But fast forward 50 years, I got three very rapid, pediatric genetics isn't pediatrics, right? We're not an age-limited specialty. We're our own, and we see adults. So periodically you get, and in our system, we're the only geneticists. So we see adults. And periodically I'll get an SOS from an adult provider, and usually in an intensive care setting. We have no idea what's going on. Can you help? And it's hard because all of our resources are over at our children's hospitals. So how do we do this? Well, I got 3 phone calls in a very, very short order from our adult intensive care units with essentially the same scenario: neuromuscular disease, unexpected clinical findings, a smattering of other things. Nothing just added up. Can you help us out? Well, I said, this is going to take me forever to sort out with my usual fashion. I'm just going to do whole genome sequencing. So I did 3 whole genome sequences on 3 patients in 3 different adult ICUs and got answers on all of them.
Wow.
Not just one answer. All 3 of those patients had at least 2 problems and one had a third, one of which was congenital, by the way. She had arthrogryposis, and now we know why. So what about better care at lower cost? Don't you understand? I can't tell you how many hundreds of thousands of dollars those patients racked up in those intensive care costs because they were getting MRIs and CT scans and EEGs and LPs and whatever other initials you want to throw in there. And all they needed was somebody to stop and say, wait, there's a better way to do this.
And if they had that data from earlier in life, maybe that also could have been prevented. Not only would they have gotten an answer quicker of going to the ER and presenting themselves there, but saying, okay, well, we've identified you may have issues in the future with these symptoms. Let's get you on a preventative track so that all of that can possibly be avoided from that.
Exactly.
Yeah, that's a really good point. And I think it is powerful to hear direct examples where we can say, this is how much they've racked up in terms of, being in the ER. And as you said, MRIs, everything else that they're doing in terms of testing, and then saying, oh, well, this could have been the alternative and saved this much money, but also just, the pain of the symptoms being experienced and, all the other effects with that. I think one of the other questions with this is, if we're, coming from the pediatric perspective, Dr. Vockley, when you have a patient coming in and you're going down that diagnostic odyssey and kind of figuring out, okay, what disorder should I be thinking of? What is on the top of my list in terms of differential diagnoses? Do you ever consult with the carrier screening that may have been done during that child's pregnancy or before their pregnancy for their parents? Is that part of the workup at all, or does that not come up as much because you're in a pediatric setting and not prenatal?
If there's prenatal testing done, our counselors are compulsive, and they'll ask about it, and they'll have those results. So yes, we'll take that into account. But it's the direction from that initial evaluation to the first tier testing, and then I'm just going to call it next tier because I don't think we need multiple tiers anymore. The direction in that from the phenotype, I think, is still important. I tell our trainees, I said, there are two ways to order an exome. One is, I have no idea what I'm doing, I'm going to order an exome. The other is, here's what I think is happening. Let's see if we can find it in the exome. And I would much rather they be the latter than the former, although far too often I'm the former. It's just the phenotypes are so hard to nail down anymore that unless you're really drilling into something that looks like Marfan syndrome, to say I think I'm going to do a connective tissue panel is almost like, just do the genome, would you, and be done with it. But if where intelligence cannot be replaced by artificial intelligence is at the level of suspicion. It's bringing that patient to genetic evaluation and genetic testing in the first place. It's being able to then say, look, this, we've met all our criteria. Whole genome is the way we're going to go here, and then we're still at a stage where I think the artificial intelligence needs babysitting. It's where we get results out from our analysis that still need a person to look at it. And I'd love to hear Stephen comment on this. I think that's going to get better over time. It's the classic machine learning paradigm. The more you do, the better you get, and that's going to happen. But I hope it doesn't mean the end of geneticists. I'd like a job in 10 years, Stephen. So don't put me out of business completely.
I think if anything, Jerry, AI empowers geneticists.
I agree.
If you don't take a good history and do a fabulous physical exam, your AI is worthless. And part of the enemy is then, well, we don't actually put that all in the EHR because the EHR is a billing engine. But provided we get the actual positive and negative findings adequately put into the medical record, then it does allow you to actually have, that 6,100 diseases in play. And so it's just a magical tool for the experienced geneticist to be able to harness, an accessory brain to help you solve the trickiest of presentations. And I think it's going to be a delightful exercise where you're going to go, well, darn it, I should have had that one, what. And the thing is that these darn diseases trick us because they don't play by the textbooks, right? They present like something else. And after the fact, we're scratching our head and going, wow, well, that's an unusual phenotype for this disorder. It's just going to be so much fun, Jerry. And, you know, you're going to be moving from, just like you said at the very start, moving from a descriptive practice to an incredibly therapeutic practice, where your focus is not so much on being a diagnostician, it's being a curative physician. You know, we get to beat the surgeons for the first time because we can cure disease. You know, we're going to fix the genetics in our patients. We're going to get them before they have progression of their disorder, and we're going to be able to give effective curative therapies. That's going to be so rewarding, you know?
Yeah, I agree. And I think, you know, we started this conversation as what's changing in pediatric genetics, and we focused a lot on diagnostics because that's where we are right now. But Stephen's right. Therapeutics is the direct descendant of diagnostics. If you don't know what you're treating, you can't treat it. But once you do, everything is in play, and the technologies for identifying novel therapies, for developing them, and I hope the regulatory paths to move them into patients are evolving at breakneck speed. That you know, when a genetic consult 30 years ago was, here's what I think you have, I'm sorry, goodbye, to here's what I think you have, here's how we're going to prove it, and then here's what we're going to do to fix it. It's a fundamentally different discipline than it was 30 years ago. I always get myself in trouble because I'll whoever I'm talking to, my favorite subspecialist, I'll say, you know, come on, you cardiologist or you're a nephrologist or whatever, you know, 10 years ago, if you just decided to drop out of society, go live on a Caribbean island for 10 years, and now you wanted to come back, your discipline would be primarily the same, right? It would be fundamentally unchanged. There might be a few new drugs. There aren't any new diseases. And if they are, they're genetic, and we will tell you about them. You know, you'd be just fine. That's not true in genetics. Genetics has reinvented itself every 5 years for as long as I've been in this business. And it's not going to change anytime in the near future. There isn't any discipline where the timeline between basic science, translational or clinical research, and routine clinical practice is as short as it is in genetics, and that's incredibly rewarding. My only frustration is we aren't getting that message effectively out to our medical students. You know, they're still going into surgery and cardiology and nephrology and not genetics. And I'm thinking, why? Why would you not want to do this? This is so interesting and so rewarding. And I think we'll get there. I think in 20 years we won't have a shortage of geneticists. I think it will be a flagship discipline that is yeah, you know, what are you going to go into pediatrics? You're going to go into internal medicine? You're going to go into genetics? You know, it's just going to be in that same breath in our medical school students.
Yeah, because genetics is at the basis of everything. So when you look at it from that perspective, it all changes because, as you said, we do need more geneticists and we need more genetic counselors and just people in this field in general. And I think, you know, not necessarily raising awareness, but I think showing how interesting it can be and how much you can impact people's lives by doing this work and preventing a lot of heartbreak as well. I do want to have time for us to answer some listener and viewer questions here. The first one is a little bit lengthy, but I'll repeat the question at the end. This is from an anonymous attendee. I remember seeing a press release about Blue Cross Blue Shield California becoming the first healthcare plan to cover rapid genome sequencing based on the work by Dr. Kingsmore and colleagues on Project Baby Bear. Despite the promising results from the research project and others, many insurers still classify genome sequencing as not medically necessary. How can we help insurance companies understand that doing genome is more cost-effective than sequential testing, panel, exome, microarray? What kind of studies need to be done? I know we talked about this a little bit, but is there any top bullet points that you would say for what we need to convey to insurance companies? Dr. Vockley, did you want to start out?
Yes. I'll try not to be too disgruntled. I think insurance companies are being purposefully obtuse here. They not only still list whole genome as research, but many of them list whole exome as research, and genetic testing in general. You know, it's this whole thing about if it's FDA approved or not. Is it an FDA approved test? If it's not, technically it's research. It's lab developed tests, it's going to take studies like this NICU study that we talked about, the baby bear study. It's going to take studies that we as scientists haven't really been very good about doing over the years. That is, showing the economic impact of what we're doing on the healthcare system, as opposed to the medical or the social impact, which is where we've always had our main focus. So that's what it's education, but it's education, you know, maybe with heavy books attached to planks, swinging them at heads. Because I don't know how else to get the people to listen. Stephen, you can be more measured than I am.
Yeah. You know, the cup is half full or the cup is half empty. You know, here's the tragedy. This technology was developed in the United States. So rapid genome sequencing for inpatients. It's now national policy in England and Wales and Australia. That's national policy. It's standard of care. Here in the US, it's not. Why not? The evidence is overwhelming. There are 24 published clinical studies. However, the news is good. So Blue Cross Blue Shield California was the first. Then Blue Cross Blue Shield nationally endorsed that. And now that's working its way across each state's Blue Cross Blue Shield plan. However, if you're in hospital X, you still need to renegotiate your Blue Cross Blue Shield individual contract. So it takes, sadly, years, even when you do have a policy. Now, Medicaid is looking really much better. So in California, Baby Bear, what was Baby Bear? The legislature gave us $2 million and said, show us, okay? You say it costs money, or it saves money and it improves outcomes, show us. So we did a Medicaid pilot in 5 hospitals, and we had about 40% of our enrollees got a diagnosis across 5 hospitals, some of whom had never ordered an inpatient genome before, and it saved $20,000 per patient. So we took that back to the legislature, and now it's law. The governor has now signed that Medi-Cal, that's California Medicaid, rapid genomes for inpatient babies in intensive care units is now law. Now that still has to go through the stuff that says, well, will that be covered by the DRG, which makes no sense, or will that be a carve-out payment? So we still get that little hiccup to take care of. However, in the meantime, Baby Deer was happening in Michigan. Similar design. Could we prove out for Medicaid in Michigan that this actually was ready for prime time? Well, Michigan went ahead and made a policy. So effective, I believe it's September 1st, Michigan will be the first state to actually have a policy that says Medicaid will pay for genomes in our state of infants in intensive care units. So I think the tide is coming in. I don't think you can stop it. I think some individual insurers are going to be leaders and some are going to be laggards, but it's going to start very quickly to become a reason why you might select one plan over another. You know, isn't it wonderful that our poorest citizens who are dependent on Medicaid are going to be first in line? Well, I guess Blue Cross Blue Shield beneficiaries were the first, but now Medicaid is going to be second. So I'm super pumped. The issue now, though, is, wow, we got to train this workforce. We don't have very many Jerry Vockleys in the US, okay? So how
That's
do
the
we
next thing. We got to
them?
start cloning him, right?
Exactly.
Well,
Yes.
we got to clone Stephen too, though, because we got somebody to run all those genomes, right? I mean,
Just like
it is
make
an
little armies of you
infrastructure.
guys so we can cover all of this.
It's an infrastructure thing, I'm glad to hear you're more optimistic, Stephen, because we still battle, and that now I'm talking largely in the outpatient setting. We battle exome for exome, and every time we find a way around one set of restrictions, they reinterpret something to make it harder yet to do it. So I'm still a little on the gnarly side here, and don't mind playing the bad guy when it comes to hitting the insurers over the head. We have to partner. I work with my the UPMC health plan. I work with them, and we have a very good relationship. And that's what we need to do. I've had health plans call me up about new drugs and say, tell us about this new drug. We'd like to know whether we're going to put it on our formulary or not. That's proactive. That's what we need to be doing with testing. I hope Stephen's right. I do see a tide coming in. I just don't know if it's a tsunami or if it's a trickle, and what the riptide back is going to be like. We'll find out.
Yeah, certainly happening, but we want it to be happening faster rather than slower.
Instantly.
There we go. In a minute. And another question kind of along these lines from Anne is, do you have any advice for new genetics providers on keeping up with all the rapid changes in the field? We've talked about how exciting it is for, us being in the field, but also for patients to have so many new therapies coming out, different ways to diagnose. Like all of this is just, rapidly changing, but that also makes it challenging to keep up with. Do either of you have any advice for how to keep up with everything?
Well, I'll maybe tackle it first. We are committing basically a third of our energy to education, because we recognize that once the reimbursement issue is solved, once the clinical utility question is resolved, that's the next bottleneck, is physician unpreparedness. And it's not so much our medical geneticist colleagues, it's the rest of medicine, because many of these disorders are not traditional medical genetics patients. They have a liver problem, a heart problem, a kidney problem, a neurologic problem. And so how do we educate the workforce and upskill them in this new science? We figure that the way to do this is 20-minute segments, which are case-based learning. So if you go to radygenomics.org and click on the button that says education, there's about 5 different streams there, and it's exactly that. It's case-based learning. We recognize that going forward, it needs to be an increasing emphasis, is practical upskilling of the healthcare force. It's not just MDs, it's also our genetic counselors, it's also our nurses, social workers, but primarily right now, the focus in particular is on neonatologists and intensivists and hospitalists, who are the guys who are encountering this for the first time. It's not being taught yet in their residency and fellowship programs.
And I have a couple of additional things to add to that. One is, we've already talked a little bit about AI. One of the advantages of AI is that it takes a little bit of the onus off of you to be able to remember lists, right? I used to hate in residency when the attending looked at me and said, "Well, Dr. Vockley, what are the 37 things that can cause spots right here?" So even if you got to 34, you were always wrong. You were always 3 short. So I don't like those kinds of learning opportunities. I would much rather be able to say, got a spot right here, and let the AI identify the 37 things, And now my job is to fill in the information to help sort that out a little bit further, and now you get it down to just a small number. And I know that Stephen's got a program that's starting to work to do this, but it pops out all of the appropriate literature for you. Just gives you a real quick overview of it, and now you've got. It's sort of instant learning. It's almost force-fed learning, but it's learning in the context of a patient, which I think is what we all do best. I can tell you patients that I saw 30 years ago. Can I tell you articles that I read 30 years ago? Of course not. Those are gone. But the patients, the stories are there. The other thing that I think we need to rely on are our professional societies. I think our ACMG, our NSGC, the ASHG meetings are all really very valuable in that regard. And you can't go to everything all of the time. It's actually been one of the benefits of the pandemic is that you've been able to get to a lot of these things virtually, and so we're going to have to figure out how to keep doing that. The live streaming that lets you pop in, while you're eating your lunch or you're sitting there and at the end of the day, and you're just if you could call watching something on whole genome story vegging. Whole genome sequencing vegging. You're sitting there while you're having your evening cup of tea and getting some information. And so it's daunting, but it's by no means undoable. And I think the components are more in place now than they were 30 years ago, because we just have so many more resources, so many more ways of bringing information to ourselves now.
Yeah, I think so. I think there's just so much available now, even with, our speaker series here of just bringing guests on so that we can talk about these topics and have these conversations, and especially be answering questions live. I think, all of these aspects, looking at the professional societies and seeing what guidelines they're putting out, that is, really good overview of like what the changes are and what is standard of care and what's coming up. So I think those are all great resources and ways to think about things. We have so many questions, and unfortunately we are running out of time. However, we're going to be capturing your questions and answering those via email. And I see Dr. Kingsmore is typing as well. So we're trying to answer all of your questions here. You'll see a feedback link in your browser when this webinar ends, and it will also be emailed shortly afterwards. Please take a minute to offer feedback to help us improve our future sessions. We really want to make these as impactful as we can and deliver the education that you're looking for. The email will also include a link to the PhenoTips Speaker Series page where you can sign up to receive alerts on upcoming sessions. You can also go directly to phenotips.com, click the resources tab, and then the speaker series will pop up on the drop-down menu. And all of our installments are on there, so you can watch them and also listen to them there. And mark your calendars for our next webinar. It's going to be on advances in rare disease diagnosis on September 9th. And if you found today's conversation interesting, I think you'd also enjoy the podcast I host called DNA Today. You can search on social media and podcast players to listen, and also connect with dnapodcast.com. So wanted to, give another shout out to PhenoTips, the sponsor for this series. They are passionate about transforming workflows through technology. Their software includes tools for deep phenotyping and phenotyped powered genetic analysis, as well as many other tools for genetic workflows. And if you have a challenge that you're trying to solve, or you're working towards making your department more efficient, you can speak one-on-one with an expert by reaching out to hello@phenotips.com. And once again, remember to stay tuned for our webinar on advances in rare diseases diagnosis on September 9th. And thank you so much, Dr. Kingsmore, Dr. Vockley. I really appreciate all of the expertise that you've provided today. And, it's still ruminating in me of just, the different ideas you have for the way we're going in the future of not just pediatrics, but I think we were able to give a really good scope out of other specialties and how all of this is impacted. And, I think the changes, Dr. Vockley, that you talked about in terms of, newborn screening and adapting to that. I think that's definitely going to stay with me of just, hopefully that's where we're moving, and it makes a lot of sense to me. So thank you both so much for taking the time and just the energy that you brought on today's webinar.
Glad to be here.
Pleasure.
All right. Well, I hope everybody has enjoyed this installment. Certainly be tuning back in with us September 9th. You can go to phenotips.com for all the information that we mentioned, including the recording for this episode. So if you want to look back, listen back to anything, feel free to do that. And we look forward to seeing you next time. Thank you both for coming on.